Sanjeev or Priya, do you have any thoughts on options for domestic resource mobilization and being more formulaic about if a country has particular characteristics, then they should do X, Y, or Z?
Thank you. I think one should differentiate across countries. For example, you have what we call fragile states. Fragile states would be, there's a definition which the World Bank has and the definition which the IMF has. So broadly speaking, there are roughly 45 countries which fall in this category. They are of all income levels. And you will have Burkina Faso, Niger, and even sometimes Lebanon has been classified as a fragile state for the way the fragile states are defined. So clearly the policies for implementing revenue mobilization would have to differ across those countries. In the case of low-income fragile states, for example, Burkina or Niger, the institutions are not there, so you have to really think of a very incremental policy. You set up the basic things first before you move on to more complex things. What has happened that I have gathered over the years is that sometimes the donors come in and propose some very modern technologies and modern systems for those countries, which they are not suited to implement. So one has to start very simple taxes that can be collected at the border or from the main sources, and making sure that the country has enough money through these revenues to pay basic salaries and provide basic services. So that system is different from a country which is a bit more stable, has gotten the basic things going. So the advice to a country such as Kenya or Tanzania would be different from the advice that you would give to a fragile state. Again, depending on the starting conditions. So the point that I'm trying to make here is that you have to take the starting conditions into account. Vietnam is in a very different state, and you would provide advice on social insurance, but you won't do that in Niger. So that's the, and then of course the nature of taxes, how you design them. Some of the systems may have to be very, very simple and crude. In some cases, the taxes will have to be second best or third best. It will not be the best possible tax systems, because you first have to get the system going, and then, especially if the country is emerging after a war or some political disruption. So that's some of the things that you have to bear in mind. And of course, in the case of health, if I may take another minute, there has been the discussion of earmarking of taxes. And of course, if Catherine wants, we can have a discussion whether there should be earmarking of taxes, and whether that kind of taxation is good for the health system, and does it really generate additional revenues. That is something we can talk about.
Just to add, from the private sector perspective, I think, certainly one size does not fit all, and then different countries are at different levels where different types of engagement make sense. So one of the things that I'm trying to work on this year will actually be creating some sort of classification system to be able to say, across all of the countries that USAID is interested in, what are some basic indicators or markers that we would be looking for before we go in, and how do we correspond that with the different ways of engaging with the private sector. So, if a company or an investment firm is interested in coming in and truly looking for market opportunities and market investments, what are some of the basic criteria or prerequisites that a country should have before that country, before that company comes in to actually engage in that way? So, I think we're still sort of trying to figure out what that level of engagement looks like, but I think across the board, one size does not fit all, and I think it's very important to take in the country context. Certainly making sure that the institutions and the regulations and the policies are in place to be able to regulate private sector when it does come in, because I think that has, that frequently comes up as a big issue, regulation of private sector, good governance practices, and that's something that I know HFG looks very carefully at. So, again, these are the kinds of things that we want to make sure, these are the systems we want to make sure are at a minimum in place, and there are certainly others, but, what are they and how do we look for them, and then how do we classify countries according to those basic set of prereqs, and then decide what type of engagement makes sense.
Thank you. I'm going to just ask you all one more question, and we'll open it up. So it seems like increasing domestic resource mobilization is not always associated with increasing allocations to health. So why do you think that is? And what might donors or implementing partners do to improve that situation, as I think most of us in the room are more interested in improving the health system? Sanjeev, maybe?
Thank you. Typically, when you look across countries, you find that revenues, as I said, have increased quite a bit in relation to total output in the economy. But not all the increase has gone to health sector. So that's, and it seems countries are spending on average a lot more on education than they spend on health. So it reveals their preferences for health sector. It could also mean that the ministries of finance are not convinced that the money which is being spent by health sector is being spent well. Therefore, they don't let the allocations go up. So I think there is this whole issue of improving the quality of spending in the health sector, or quality of spending in general in many of the countries where the inefficiencies are quite evident. So one has to make a case for health sector against other sectors, and also since the typical highly indebted poor countries debt relief initiative which took place in early 2000s, where the emphasis was on increasing spending on social sectors, both education and health. Since then, and the emphasis seems to have shifted in favor of infrastructure. So that typically you do find governments placing heavy emphasis on infrastructure, and which could include health infrastructure as well. And infrastructure does enable access to health facilities. So it's not that infrastructure is totally incompatible with health. But it seems that when you start discussing with policymakers in countries, they feel that something which is really impeding growth is lack of infrastructure.
Well, I was thinking of, again, the examples from my experience. In Vietnam, we were trying to convince the government to raise more money for specific programs like HIV. So in addition to what Sanjeev said, trying to get the ear of the Ministry of Finance, and in our case, the Prime Minister, for the plight of, people with HIV, I think what worked for us was really to look at some of the higher commitments made by the government, especially in terms of universal health coverage. So that was a commitment that it goes beyond, Ministry of Finance are interested in that. You can talk to them about that. And we could talk with the Prime Minister about universal health coverage rather than having to single out specific programs. And when you can show, for example, that only 40% of people with HIV have health insurance compared to the 80% of the regular population, that's a good argument to understand that, the key populations are being, underfinanced, and that the government is not providing enough attention to that in the name of, a larger commitment. So I think, again, of course, the obvious response is try to strengthen the arguments that the Ministry of Health has, but linking those arguments with a commitment that is government-wide, and they can, be clearly understood by Ministry of Finance, by the Prime Minister, by Congress, National Assembly in the case of Vietnam, I think was very powerful for us.
It's interesting to have this conversation and then think back to some early health economics kind of 101 classes where one of the first things they tell you is that health is a public good and it must be provided or paid for predominantly by governments, and that's why you don't have a lot of private sector engagement. So it's interesting to come in from the private sector side and then hear about all kinds of other market failures on the public health side. So I think from the private perspective, I think a lot of the trends that Sanjeev mentioned also sort of parallel what you see in their private sector side, which is, it's not immediately obvious where there is a role or room for private investment in health. I think infrastructure is one, certainly investment in research and development for health technologies and commodities is another. But when you're talking about resource mobilization or increased investment for health, finding those opportunities are still quite difficult. And I think that's the case not just in many low and middle income countries, but certainly in high income countries as well. And so trying to find those opportunities of shared value with private sectors is a continual challenge when there are other areas where they can easily see a return on investment. So we're talking about energy, infrastructure. It's much easier to see where and how private sector would be interested in playing that space. So I think a couple of things that at USAID we're really trying to think about. One, what is our role as a public sector entity in terms of de-risking private investment? And how can we do more of that using some of the financial tools that we have available to actually incentivize and interest private investment into the health sector in many of our countries? But then also, how can we be much more efficient and effective with our existing resources? So there's now been not a new trend, but I think renewed interest in looking at things like pay for results and then pay for success type mechanisms. And, what is the role of private sector in helping provide maybe working capital for implementing partners, while USAID and other partners sort of really purely pay for outputs. And so I think those are sort of other trends that we're seeing while we're trying to think a little bit more creatively about what our role is in terms of mobilizing more resources or being much more efficient and effective with our limited resources. The other thing I was thinking about when Sanjeev was talking was, the IMS Cascade, that I think their new CEO was presenting, which is a program that sort of looks a little bit like a waterfall. And what it's meant to do is sort of be a little bit like a decision tree to say, if ideally what we're trying to look for is separation of opportunities for private sector and public sector, how do we go through this thought process to understand what needs to happen in order to be able to identify those opportunities? And so it's been a while since I looked at it, but if we take an example of an airport, right? Sanjeev was saying often you'll see public sector pay for infrastructure, so building of airports, for example, when really this could be something that could be done by the private sector, and maybe those public resources could be freed up for something like health. So then what needs to happen to identify those opportunities and be able to move down this cascade of different types of risk and capital to get to an opportunity where private sector says, aha, yes, I'm actually interested in investing in this airport, and I think this is a good business opportunity for me. And so I think part of what also needs to happen is this larger dialogue across donors and sectors, both within countries and at a higher level, to say, how do we identify those opportunities where private sector really should be taking on all of that risk and that opportunity, so that we're shifting the burden and we're opening and making more resources available from public sector to go to those more socially minded sectors like health and education, where those opportunities for private investment might be smaller or much more limited.
So it's interesting. So in answering the question, what might donors and partners do to promote DRM for health? It's improving the quality of spending by the public health sector that increases their credibility with the Ministry of Finance, and in and of itself obviously has merit, and paying attention to the political commitments of the government and focusing on those, and focusing on outcomes as opposed to, we need this exact amount of money. It's more talking about and the impact on the beneficiaries and playing a role in guiding private sector investment to be looking at more social sectors and differentiating what the public and private sector would do. Do you have any other reactions or? Because I think, one thing that struck me is that it's not so much about, investing in better tax collection per se, but a lot of technical assistance with the country counterparts to build up their capacity to pursue an agenda that they're already kind of invested in and kind of, playing to those commitments that they have.
Yeah, that would be definitely my suggestion, and also dedicating enough time working with the country to be able to do that. We are used sometimes to very short terms of engagement that allow us to maybe come up with a sustainability plan, to come up with common recommendations and all that. But I think what is really useful is to spend enough time in a country and understand what's already taking place. As a consultant, one of the most repeated sentence I've heard was, someone already did that, or someone already thought of that. Whenever you try to present something new, 5 years ago, another consultant tried to do that. So there is stuff on the ground, but I think we need time to take a look at the political economy and see why certain solutions are not being taken up.
Very quickly to add to that, yes, I think, M&E is important, but certainly we have different timelines and expectations for how long the M&E is going to take versus when we actually start to see impact of some of our activities. So it's also expensive. And so there are real trade-offs to really trying to understand the long-term implications, especially if you're trying to calculate something like a return on investment of our program. It's not going to be immediately obvious, especially if you're asking for investment into things like health and education sectors where the payoff really is in the long run. And so I think part of the onus on donor agencies like USAID, for example, is to think a little bit more critically about how we can do M&E over longer periods of time so we can really capture those benefits and then be able to go back to say, look, this is the return on your investment. And that, I think, is the case for both public and private interventions.
So now we can open it up for people to ask questions of the panelists or contribute to, because I know a lot of you work in this area yourselves. If anybody.
I didn't look behind me, so that's appropriate. I have two questions. One for you, Steve Warren from Deloitte. One for the IMF. Formerly IMF. The efficiency of the taxation is one of the big issues. And what I'm wondering is your experiences, if you can relate. You can press a consumption tax if you want, and a prevalence of it. Or as you mentioned, you could work on initiating the income tax and or some other kind of retail flat tax. The one question we have when we try to raise domestic resources is on the consumption tax side, particularly the VAT side. How can we reduce the exemptions in that system itself? That seems to be a rat's nest of political economy. It was in Egypt when I was just there. It was in Vietnam, was an issue. How far do you push before you're way past ellipse second best? You're way down the stream. And say, okay, now we're going to start giving advice on income tax, which may have a far less revenue collection, even though it's progressive intentionally. The second question I had was regards to the spending itself. As the domestic resource mobilization rises rapidly, the donors' influence, of course, falls significantly. We used to have an awful lot bigger share of the pie of money and therefore a lot of influence over presumably how it was spent. Are you, say, Priya, finding, or in Vietnam, are you finding, as the governments soar in their domestic resource mobilization well above what
they used to get in donor contributions? Are the efficiencies of their decisions getting better? Because it's not about health. Health is what everybody does here, but it's not really about that. It's about improving human capital in many ways, which is why infrastructure crowds out these decisions half the time. What's your experience on the sophistication of the decision making as they become wealthier and we become less relevant? So, 2 questions on that.
The question that you raised is a very relevant one, and once again, I'm not speaking for the IMS, but so the exemption issue is politically very difficult in most countries. For the audience which doesn't understand, let me perhaps explain what it means. It means that on some items of consumption, there is zero VAT, zero taxation, and those goods could be food items or medicines or something else. The implication of that is the administration of the tax becomes very complex. There are leakages, and so you don't really achieve the maximum efficiency that you should achieve in implementing the tax. So that's the issue which has been raised by Steve. And now, the new technology that I mentioned can potentially address this. How will it address it? Suppose you have in a number of countries, they have put in biometric technology in place. In India, they have 1.1 billion people who they can track biometrically. And there are 76 countries where biometric programs have been put in place. So if potentially you can say that I can provide subsidy to the people who are poor through this biometrics system, then I don't need to have a program where I'm trying to protect the poor through an exemption system in the VAT. So new technologies can potentially allow you to overcome these issues. But I understand even UK has a lower tax on food items and for political reasons. So this is certainly an issue which has to be dealt with. Income taxes, certainly we all would like to impose income taxes. People who have the ability to pay should pay more. But it also means that you have a system which can track the incomes and can enforce the system. And so it is in many countries it's not going to happen very soon. So you don't see more than 2% of GDP revenue coming from income taxes. Same thing applies to property taxes. That doesn't mean you don't impose those taxes. Those taxes have to be imposed mainly because they create a perception of equality. Because given the income inequality discussion that is taking place, we have to have taxes on these areas. But at the same time, it is not going to yield much return in a short period of time. On the other hand, corporate taxation is an issue because you do come up with this leakages through profit shifting that happens with multinationals. So, which is a subject of its own. So I will not go in there. The second issue.
Yeah, the second question was, as they get better at domestic resource allocation, the influence of donors decline.
Well, if they get better at resource mobilization, it works.
They may.
I would argue not many countries are very efficient, I think. Yes, relatively speaking. So I think the closest parallel that at least I can speak to from my own experience, not necessarily at USAID, but working domestically and then within European markets is looking at things like decision-making around pharmaceuticals and commodities for pricing and reimbursement. So I spent some time working for the British Pharmaceutical Trade Association in London and working with NICE, so it's their National Institute of Health and Clinical Excellence, and looking at how they through the NHS or with the NHS made decisions around which pharmaceutical products to reimburse and at what price. I think one of the trends that we're seeing, certainly within USAID, and I know USAID is funding a lot of this work, but certainly there are other groups out there doing it, is actually helping countries set up systems like this. So PAHO, for example, has done a lot of work in Latin America, working with them around kind of making those types of decisions around pricing and reimbursement for pharmaceuticals. Thailand, for example, has set up HITEP, which I think has, you could argue, worked very well in that sense in terms of helping countries use the existing resources that they have much more efficiently to maximize health outcomes if that's your end goal. So I think, as we start to see country incomes rise, certainly as there's been an increased push towards universal health coverage, there's been an increasing look towards, what should go under a pharmaceutical benefits package, what should go under a health insurance package as sort of basic services that should be provided and at what cost and to whom. And so I think I don't know that anybody's quite figured it out yet or anybody's there yet, but I think we certainly have models in, developed countries, but then also in a lot of developing countries like in Thailand where they're implementing certain policies or certain ways of looking at efficiencies quite well. And the trick will be, how do we expand that, say, beyond pharmaceuticals and commodities, but then also think about the implications depending upon the country context and making sure that everybody has access to that kind of basic package of health services.
No, it's actually a continuation of your answer. And you mentioned Vietnam directly, and Vietnam is looking at Thailand, trying to improve their issues with pharmaceutical management. I think social health insurance spends up to 50% of their budget on drugs. And we did an actuarial analysis of, where these drugs go in the system, and there's a lot of inefficiencies there. And, the Ministry of Health kind of put the report on the side, trying to figure out how to deal with that. So a lot of abuse in terms of prescription, and a lot of use of machinery for diagnostics, a lot of mix with private sector leasing machines for shared revenues. A lot of issues that I think might have been there already with donor funds, but definitely are exacerbated by the fact that nobody's really watching.
Any another question or comment?
Hi, I'm Beverly Johnston, and I'm with USAID's Office of Population and Reproductive Health. And I actually have a question for Sanjeev. You mentioned a bit about tax revenue, and I was hoping you can comment on the pros and cons of tax revenue that is specifically allocated to health elements, specific health elements, and maybe like just what have you seen and something lessons learned from going down that route or hoping to go down that route for some elements?
So this was the issue of earmarking that we talked about, and typically we discussed this in the context of the tobacco taxation. And so in general, there are a number of issues that arise with earmarking of taxes. One thing which we have seen is when there is hard earmarking, that you say that money which is realized from taxing tobacco will only be directed to health, that goes outside the budget process then. It becomes non-transparent and how the money is being spent. So this is not consistent with good practices of budget and budgeting. So that's one aspect. Secondly, we have to bear in mind that when the Ministry of Finance sees that revenue is coming from earmarked sources for health, they're going to reduce their allocations. In other words, there is the issue of fungibility, which exists in all allocations. So you don't see a net increase happening on a large scale. So, I can discuss tobacco in a taxation in a big way because I was involved in a project. But the point here is that if you're looking for additional revenues for health sector through earmarking, A system which has been proposed and discussed is a soft earmarking. In other words, which Philippines has used. What it means is that if government says, look, we are going to levy more tax on cigarettes, and we will make sure we give a commitment as part of the budget process to increase allocations for health. And that happens every year in the budget context. It's not outside the budget. That is fine. That is the way one could proceed with this. But otherwise, hard earmarking, which some countries have used, and the countries like France, Canada, and others which have reduced the incidence of tobacco smoking, they have not followed hard earmarking.
Arlington from HP Plus. So this question to Sandeep, I think following up on taxes, we've got taxes on the mind. Just the political economy of how taxes are mobilized, if you could give us your opinion. We touched on this before in response to Stephen's question. So in economies like Kenya, where we're seeing a better mix of direct taxes and indirect taxes, the elites seem to have a little bit more resistance to how direct tax income is being applied. And there seems to be, I mean, this is anecdotal, some preference to investing it in infrastructure, things that support the sectors from which those taxes are raised. In other African countries, we see a much more indirect tax-based tax structure. And there might be, yes, it's regressive, but since these are raised from the informal sector, from the broad population, there seems to be a perception they can be used for social sector uses. So could you tell us a little bit more about the political economy of how taxes are mobilized?
You are right that there are some political dimensions to all the taxation policies that countries follow. Last year, I also did a book on political economy and fiscal policy, and we looked at the how elections, political divisions, and ideology end up reflecting the policy choices in fiscal policy. All those things do have an impact. But in case of Kenya, the example that you gave, it is true that indirect taxation is progressive, right? Progressive in the sense that poor share of consumption is more in the total income. So they end up paying a lot more taxes. So it's not very progressive in that sense. But if you were to use this money to spend on progressive areas, let's say providing universal health care, which benefited the poor more than it does the rich, then you offset the negativity that arises from the regressive taxation, and so there is a way to deal with it, but the assumption here is, and this is a big assumption, that you're spending it well. So if you're not spending it well, then you do have this issue of progressivity. On the other hand, as I said at the beginning, you don't really have a choice if you want to raise more revenues. Potentially, that's where the revenue is going to come from. So the onus then falls on improving the quality of spending. And that's where the political economy issues come in. You have to make sure that people who should get the benefit do end up getting the benefit. The benefits are not captured by the rich people. So the design of programs become important. The implementation becomes important. And so that's something which is important in the political economy of taxation. Sorry about that.
Cindy, I feel like that gets to your question about donor influence on how governments spend their money. Your original question. Another question? Yes.
Hi, my name is Catherine Bertram. I'm with Johns Hopkins. And I apologize, first of all, I came in late, so I'm sorry if you talked about this a little bit before, but I was intrigued by your conversation at the tail end of the conversation about the private sector and engaging them in investing in projects like infrastructure to free up funds for health. And I was wondering if you can just talk a little bit more about that, and if you know of any examples of this happening, and what guarantees, I guess, do the public have, and what incentives does the government have to not then reduce funding or to basically continue to use those funds for infrastructure projects?
So this was based off of an IFC or IMF kind of concept, which they're calling the Cascade, which is really about thinking about how and what the role for public and private capital is, and how in this particular case the IMF can think a little bit more strategically about ways in which it can use its resources most effectively and efficiently. And so the example that they gave was an airport, and I can't remember where it was, but they were working with some country government to basically say, look, you actually don't need to build this airport. Let's figure out what is the minimum level of intervention that we as the IMF need to provide or do to get this private funds to build the airport. And it was this sort of cascade approach, this decision-making process to say, does it need to be, will private sector take it on? And if so, great, then we let the market function. If not, does there need to be some de-risking? So is that in terms of, an actual credit guarantee? Is there, a loan that maybe needs to be provided to kickstart this process? What kind of de-risking needs to come into place? Does there need to be co-funding? Does the IMF need to put some grant funding towards this project to catalyze private investment? Worst case scenario then, sort of at the bottom of this cascade, is there needs to be sort of full public support for this particular intervention, and so the public sector will take on the majority of the cost of building the airport. And so that's sort of the principle behind this cascade. And the argument there is that there should be separation, or there are certainly opportunities where private sector is best placed to take on certain projects and then free up, theoretically, then resources to go towards public sector. So I kind of use that roughly as an example of ways in which there should be separation, or there could be separation, if we adhere to the first principle that health is a public good and should be predominantly public sector funded. Again, that's questionable and arguable. In almost no country is that actually the case. In terms of then guarantees that the public would have that would necessarily free up resources on the public sector, I think that's where this then becomes an ongoing conversation, and this is where those political commitments really, really become important, because there is no guarantee. But certainly I think having, this is maybe the role of, CSOs, for example, to really lobby hard and work with their country governments to make sure that their voice is being heard, they're being represented, and that there is kind of this demand from the population to say, this is critical for us. This is something that we really believe in and we want. And, that then becomes, at least a mechanism by which a government is held accountable to a certain extent for using those resources. But I don't have necessarily a good answer for you. I think that's part of the ongoing dialogue and conversation that has to happen.
Maybe one last question, and then we'll take our break.
Hi, my name's Edward. I'm from the Assist Project. I was wondering if there are any good models out there for domestic resource generation from resources that have been earmarked for social spending, health, education.
And can I also have that in Asia and Africa?
I'm not sure I understood the question correctly.
So resource generation from, earmarking of income from taxation of resources that is being earmarked for social spending on health.
I gave you one example of the Philippines, where they have earmarked tobacco taxation for health, which could be viewed as a good example because it is soft earmarking. It is going through the budget. It follows the good principles of transparency, and it has led to increased spending on health. So that is, and I think there are some other examples which don't come to my mind, but there are a couple of papers which have been produced by WHO, and there's a paper which came out last year, and I can remember one of the authors' name, which is Susan Sparks, and you can have a look at that paper, which gives the examples of countries where the earmarking in the soft way has helped in raising some more revenues. I don't know about other sectors in education, etc. Countries have imposed some small cesses to be able to collect more revenues, but they don't really make much difference in terms of. And the bigger issue that I raised earlier was when you have this kind of earmarking, what is the counterfactual? Would the spending really would have increased or not in the absence of earmarking? Because, as I said, money tends to be fungible, and so if when additional resources become available from earmarked sources, allocations to that sector gets, reduced as a result at the time of the annual budgets.
Yeah, I just wanted to say that right after the break, we're actually going to do a deep dive into an Asian country and an African country that gets at your question, but not just earmarks, but other ways that this is getting accomplished. Last word.
Sorry, as we were doing okay for time, I thought if it's okay, I'd like to ask the panel a quick question. All the arguments you're making are very sophisticated, and I think no one's going to disagree with the points you're making. But many of the international donors actually seem to go around things very differently. It's like if there's an emergency out there, mothers are dying, people are dying in areas, let's get the services out there. Philanthropics set up projects and they get service expanding bilaterals to it as well. And then the idea being that once the service is there, once everyone accepts the service must be there, we'll find out how it's going to be funded domestically in the long term. That's sort of very crude what you're thinking. Is that totally irresponsible, or do you think that it's inevitable given the fact that there's so many emergencies in low-income countries? And, I'm interested, obviously, not just for USAID, this is the local fund does this, often the money is off budget, but it's such an emergency, you get out there, you get the services, and we work out domestic funding later. I was quite interested before we finish the session to get your views on that, whether it's appropriate or whether we should be moving away from that. This is go on, thanks.
I think my brief remark would be that we prefaced at the very beginning that each country will be in different stages and there will be different approaches for each country. So I totally agree with you in the sense that there will be countries that will not be able to generate enough domestic resources for health, and definitely will run into issues of humanitarian nature that will require support. So from my standpoint, I have in mind a certain category of countries, lower middle income countries, that are ready to not only generate more resources, but also use those resources to take the place of external financing. There's a whole other area and socioeconomic countries in certain socioeconomic condition where that type of support is still very much needed.
So I don't think it's totally irresponsible. I mean, if you look at what Gavi, Global Fund, even PEPFAR and PMI have been able to do since they've started, it's incredible. And so I don't think that we should sort of undermine the value that these programs have done in terms of literally saving people's lives. I think now, though, that model of engagement needs to change. I think, we, and humanitarian sort of crises aside, I think now we're thinking about the longer-term sustainability and impact of these programs. And I think certainly, as budgets decline or, and donor budgets decline or start to plateau, we need to think a little bit more differently about what that engagement looks like. We can't afford to keep many of these projects going, and that certainly doesn't mean that we should stop funding them completely, but we do need to start thinking about what transition looks like and how we can bring in new players, whether that's domestic government resources, whether it's private, whether it's new donors coming to the table. We do need to start thinking about how we transition, and that's certainly a priority of this particular administration as well. And I think, we're being pushed much more, maybe we're being pushed harder, I think, to really think about what that transition looks like. And that's certainly not unique to USAID. A lot of other donors are starting to think in that way as well. And that's why I think, these conversations are beginning to happen, and there are more players coming to the table thinking about DRM, thinking about private sector engagement and innovative financing. Global Fund just elected a new, executive director, and he's very interested in innovative financing. If anything, one thing I heard was that all three of the candidates that were being interviewed brought up innovative financing. So even, large entities like Global Fund and Gavi are starting to think about what their long-term sustainability plan is and how they can build that into their programming and how they work at the country level. So I think this is a larger trend. Hasn't been irresponsible, but I certainly think we need to pivot a little bit as a donor community and think about what our engagement will look like in the next 10, 15, 20 years.
To answer that question in 1 minute that we have, I think for the shocks that you're talking about, of course, the assistance from outside can help. It does help. It makes a big difference. It saves lives, and because countries can't generate all those resources in a short period of time to meet the contingency. So clearly, this is a good thing that happens when donors step in and provide short-term assistance. And because the budget systems can't handle that inflow, it's okay to put it outside the budget. The issues arise when you have other assistance that is going outside the budget. Then how do you transition the issues that Priya is raising? The money is going outside the budget. The countries have no clue what's going on. And that money is now, the programs which are being financed are being told to the countries that they should absorb them in their budget. There could lead to huge amount of duplication. And the spending may be a lot more expensive than in the domestically run programs. So it raises a whole lot of issues when you do things outside the budget on a sustainable, on a long-term basis, and then you ask the countries to absorb those resources. That raises a whole lot of issues. I think that need to be addressed.
No reaction. No reaction. All right. Well, thank you all for joining us on this first session. And I want to congratulate all of you and thank you. We're joined back by Studini, who I mentioned at the beginning was our chief of party in Vietnam, and now we welcome Elaine Berua, who's a health economist on the HFG project, and she oversees our program in Nigeria, where they're doing working on several different fronts to mobilize resources for health. And we're going to save a lot of time for questions. All right. So we're going to start with Nigeria.
Okay. I might get up in a second because I do have a bad back, but Just want to say thank you to everyone who persevered on the public transport this morning. Bless you for making it worth my while, because I came in all the way from Baltimore, so I really appreciate that you made the effort and stuck with it. So as Catherine mentioned, I'm the country manager for Nigeria, and I'm going to talk to you a bit about what's going on in Nigeria around domestic resource mobilization. And Jen is going to throw a book at me in about 10 minutes if I'm still talking. So I am glad that we're not using slides, because that means I can sort of tell you it as the story, which is much more interesting, and I even have voices for you, so look out for the voices. In 2014, Nigeria passed the National Health Act. There were lots of good things in this bill that was passed by the government. It had impact for private providers. It didn't touch national health insurance much, but what I want to focus on today is that it earmarked 1% of Nigeria's consolidated revenue for the provision of a basic package of health care that would be consisting of primary health care services that would be focused at vulnerable. The definition of vulnerable is quite broad. It can be indigent, it can be pregnant women and children under 5. I think it was left intentionally broad. But it earmarks 1% of consolidated revenue. This bill was passed in October 2014 under the previous administration. In November 2014, when the budget came and went, that 1% revenue was not satisfied for health. At the end of 2015, when the 2016 budget was passed, it was still not in there, and we had a new government. At the end of 2017, it was still not in there. Now, a lot of work went into designing the National Health Act and getting it passed. I think it took, the better part of about 4 years to pass the National Health Act, and that provision has not been implemented. It's a significant amount of money, 1% of the nation's revenue. I'm not good at math, so I can't do the translation in my head. But for example, this year's revenue is estimated to be about 6 trillion naira. So anybody with a calculator can divide that by 350. It's several hundred billion, right? So 1% of that is quite a lot. Of money. For this year, it would be nearly 100 million. So the fact that it hasn't been implemented, and it's a law, it's an opportunity, and we saw it as an opportunity. We work at both the state level, so we work in this year we're working in about 16 states, and then we do a bit of work at the federal level as well. So we saw this as an opportunity to get something done. The law's already been passed. Now, how do we get it implemented? So we had to try, the first thing we had to do was try to understand who gets it implemented, all right? Who's responsible for making it happen? And working with the Ministry of Health at the federal level and the Ministries of Health at the state level, we're able to identify several groups of people or institutions that needed to be engaged. So the first one, this probably sounds obvious, is the executive. So Nigeria is a federal structure, so it's not different from the US. So the executive, so that would be the Office of the President and his executive committee or his ministers. The next group would be the legislature. So the legislature are the people that pass the bill, right? So the executive sends a bill to the legislature. An example of a bill would be a budget. The legislature approves it, edits it, approves it, whatever, and sends it back. The president signs it, and it becomes the law. And then the Ministry of Finance or the Treasury is responsible for implementing that. So those who said they were supposed to get this will get this, and those who were supposed to get that will get that. So that's 3 groups of people. Then we came across as we were doing this, we're thinking, okay, so what do they know about this bill and about implementing it? And the answer was, it turns out, not a lot. Because, like I mentioned, the year after the bill was passed, there was a change of government, and it went from one party to the next party. And so there was a raft of new legislators. So this was not their priority. and nobody made it their priority. And I think the Ministry of Health recognized that this was a mistake. There was no effort made to let legislators know that they had a role to play. So how do we get legislators who are politicians? What's the first way to get legislators involved? It's the same as it is here, engage the media, because legislators love media. Whenever I go to meetings in Nigeria, I find it very interesting now that when the Ministry of Health comes, he brings an aide. But when a senator comes, they bring a photographer. And it gets me thinking that, there are different priorities here that we need to work with. So engaging the media to make the legislature realize that, this is an important issue, that people are watching them, that there are expectations of them. All of this is important, but nobody had engaged the media either. So the media wasn't writing about this issue. And if the media is not writing about this issue, then the public isn't engaged either. So at least from the beginning, we had a rough idea of the groups of people that we're thinking, and we went out to look for this. We did, political economy assessments, we did government assessments, we tried to understand what is going on. We didn't have any specific steps to take initially. So pending that understanding, one of the activities that we've then since implemented is something called the Legislative Network for UHC. It's driven by the Senate Chair for Health. And the reason I think that we sort of went with this, part of it is because the Senate Chair for Health has a vested interest. He's also a medical doctor, and he's really engaged. And we've actually learned quite a bit from him about how the legislature works. And he's made really valid contributions to, thinking about domestic resource mobilization more broadly. This morning we had a lot of discussion about the private sector. Most of the countries that I work in, the Ministry of Health looks at the private sector and thinks, here be dragons. We can't regulate them. We don't know what they're doing. We don't want to know what they're doing. We're busy working with our public sector providers. We don't have time for this. And it's interesting because when you do engage the legislator, private sector is almost one of the first things they say. What's the role of the private sector? Where do they come into it? But we haven't really thought through. So he brought a lot to the table as well. So we launched the Legislative Network for UHC. One of the things I will say that was very pleasant launching that network under the leadership of the Senate was we had no trouble engaging partners and other donors. It's very interesting to me. The idea here was about really focusing on financing for UHC. And every partner got engaged, every single one. The WHO, the Gates Foundation, USAID, the bank, everyone with, there was no need to persuade them. And they put their money where their mouth is, because having formed the Legislative Network, one of the things we realized was we had this big launch. We had legislators from nearly all of the 36 states, not all of them. And we chose to have the ones that had a role to play, we thought, had a role to play in health financing. So that would be not just the committees on health, but appropriation. And then the Speaker of the House, the person who communicates between the House and the executive, the Secretary to the government. We chose the people that our political economy assessment said have a lot of influence and have the ability to bring both legislators and the executive together to discuss issues. We brought them together and we launched this legislative network. And one of the things they said very early on in the sort of 2 days was, exactly what is it you want us to do? And that was kind of like, whoa, you don't know what you're supposed to do for health financing? That was a bit of a shock. I mean, we knew they didn't know that much about UHC, but in terms of getting your health budget passed and getting your health sector strengthened, they really didn't know what their role was. So the main activity we've been doing under UHC and the Legislative Network for UHC over the last sort of 6 months is working with the legislators to make them understand their role with regards to health financing, because it's critical. They make the policies. They can make good policies, they can make evidence-based policies, or they can make really bad policies that don't get implemented. They deal with appropriation. So they decide what budget gets passed. They have the power to put things in the budget if they're not there when they first get it. And I think that's one of the core results of the network to this point. In December, when the executive sent the federal level budget to the legislature, again, there was no provision for that 1%, the Basic Healthcare Provision Fund. And the Senate put it back in, and are sending it back to the executive and say, we're not going to pass this. It's not the only issue they had with the bill. We're not that great. But it's one of several. But it is there. So now it's going to go back to the executive with it, and they're going to say, we're not passing it until you put the provision for this money aside. So they can do a lot of things around appropriation. They also have a critical role to play around oversight. It was mentioned this morning, it's not just about raising, how you spend it as well. We can easily raise money and then not spend it on things that lead to UHC. We can easily raise money and not spend it on things that improve equity, that don't improve the healthcare of the vulnerable population. This particular initiative, or this particular money, is exactly directed where it needs to be. Nigeria being decentralized, primary healthcare is at the lowest level of government. It's also the weakest level of government, and when you think about trickle-down public financing, it's at the level of government that gets the least amount of money. So of course primary healthcare suffers. This money is money that will flow directly from the federal down to the primary healthcare level, without giving too many people any opportunities to put their hands on it before it gets there. So it's a particularly special piece of legislation that's really worth pursuing. But the other thing about oversight is that they didn't know the role they could play in oversight. Ministries of health should not be defending themselves once a year when the budget comes. Legislators have a role in law of doing the oversight of Ministry of Health. It shouldn't happen once a year, it should happen all the time. It should be after the first quarter. Have you submitted all of the things you were supposed to submit to the Ministry of Finance, and have they released their money? And if they haven't released the money, the legislators can go and ask the executive to do it. If they have released the money, what have you done with it? They have the role of visiting, for example, health facilities to see, is the Ministry of Health at the federal or state level doing what it's supposed to do for their own population, their own citizens? They have that role, they didn't know how to do it. In fact, it turns out in a couple of states, they had the role, they didn't know about it, money to do it was actually in the budget. They just never used it. It was just there, carried over from year to year, money to do oversight, but they never used it because they didn't know it was there. So there's critical roles that they have to play that they didn't know about. So I've talked about policy making, appropriation, oversight, accountability. And I think accountability and responsiveness, we're a governance project, so we're big on those types of things. But accountability and responsiveness, they're tricky, but they're very real at primary healthcare level or at the local government area level, as we call it in Nigeria. So accountability to the population. Are you providing what they need? It turns out, and this is going to be really logical to you, but it wasn't obvious until we started talking about it. The first time we were working, the first training that we did with legislators, and we were talking about what their communities needed, we said, when you're doing this oversight, you should be asking the Ministry of Health, what is the Ministry of Health doing, State Ministry of Health doing in your community? If you look at the budget, for example, and you look at their expenditures, and it's all being spent in the state capital on some secondary level facility, that means the people who are voting for you are not getting what they need. You have a mandate to question the Ministry of Health and say, wait a minute, but what are you doing on primary health care? What are you doing for my community? You have the power to do that if you just ask them. And then they'll have to do it. And that's to everybody's benefit, because that's where we're weakest, that's where we can save those lives. So this really is a win-win for everybody. It's just that nobody's really paid attention to it before. So there's accountability. And then finally, there's responsiveness. And this is where the media comes in and the population. If the population has needs, and you make it clear to politicians using the media, using civil society organizations, that we're going to make a lot of noise about these things. We're going to involve them. Many CSOs came, and all the media came, to the launch of the legislative network. The day after, the thing that we went around making sure every paper got is, do you make sure that you quote the Senate President? Because the Senate President, not the Committee of Health, the actual Senate President, said that if the Ministry of Health brought his budget and specifically pointed out the need to earmark that money. He said in public that he would guarantee that the Senate would make sure that the bill for the budget contains that money before he sends it back to the Vice President. And that was on the front page of The Guardian and This Day, which is widely read papers. That was important. Our USAID client was really excited to see that because she said, even though it's been in the bill, no public official has actually said that they would do that before. That was the first time. And that's because he was, he had a phalanx of media in front of him recording his every word. And he had 250 legislators in the room who we told, this is your responsibility. This money is coming from the federal all the way down to you. It's your money. You need to ask for it. You need to make sure that it gets put in the budget. And they have made their voices heard. We are taking the training to the Governors Forum, again, another avenue where these legislators here who elect their governors, they're going to raise that issue with the governors so the governors can raise that issue with the president, because governors, like you, are very powerful and have a lot of power in the budget. So it's been a really cool experience engaging with all of these very, very different types of folks. I think the Ministry of Health has been challenged because this is not the type of engagement they're used to. And it's required them to really think about, in terms of affording it, we've had to collaborate with all of the partners because it wasn't in their budget, it's something to do. But they've collaborated well. It's involved engaging the media strategically, not just having an event and calling the media, but actually having a plan for how do we use the media to put pressure on the presidency to include this money. And, the other group, state legislators, federal and state, have never talked about health together. And yet both of them play a critical role in ensuring that primary health care gets delivered at all, but they've never had that conversation. Ministries of Health said, we had state commissioners who said, I've never talked to the chair of appropriations before. I've never had him come and look for me, as he did after the legislative network training. It's always me going to him when a budget needs to be defended. He came to look for me to say, where are we in the Ministry of Health, State Ministry of Health budget? So it's been a really cool experience. The 1% is in the budget now, and it has gone to the executive. It goes to the executive this week and next week. There's a whole strategy of media campaigns that are going on right now to make sure that it stays on the front page, or at least page 2, so that they realize this is an important thing and that they should just do it, like they did it for education. This is not really innovative or new, it's just more emphasis. So that's my story.
So, making earmarks work with a legislative network and media engagement and others. And Vietnam's a very different story, very different.
Very, very different story. So in Vietnam, we have a clear example of one of the countries where I thought DRM became the central focus, something that we report on. And mainly because the Sustainable Finance Initiative got interested into Vietnam, and started putting specific numbers on in terms of return on investment that we had to report on. But going back, so the situation in Vietnam, in 2014 when we started, we had over 70% of the budget for HIV being provided by external funders, mainly PEPFAR and Global Fund. And, we have a concentrated epidemic. So politically speaking, the fact that the key populations affected by HIV in Vietnam are mainly people who inject drugs and sex workers is not really palatable in terms of keeping financing a program that they publicly allocating funds for that. So that kind of limits some of the options. And so when we started, actually, even though since 2012, the government of Vietnam had identified social health insurance as the main financing mechanism for HIV, nobody had done anything about it. And I have someone who worked in Vietnam before me, so she can provide a little more context to that. But the point was that because of entrenched interest and also because of people being used to it, the goal that everybody was trying to accomplish was to get the government to keep funding vertically the HIV program, just replacing the money from PEPFAR with government funds. Well, again, politically, that was not really a sellable idea, but I want to just give you an anecdote to at which point the Ministry of Health and especially the Vietnam Agency for AIDS Control, VAC, realized that that was not a great idea. There was a famous meeting, infamous now, where a lot of development partners were talking to the National Assembly, which is Congress in Vietnam, and especially the Social Affairs Committee. And we were all advocating for HIV, and the lead speaker was the Agency for HIV and one of the international advisors to them. So at that point, the option of direct funding for HIV was very much the one in favor. And so this is an example of what not to do. The HIV agency went in with the investment case in one hand and a big picture of a Boeing 747. Now, why the Boeing? Because a couple of weeks before, Vietnam Airlines had bought new airplanes, at a cost of, let's say, $120 million each. So what was the pitch? The pitch was, here's the investment case. For the price of a Boeing and the stroke of a pen, you can end this problem to National Assembly. And so there were a few chuckles, some raised eyebrows. Just, to make the story short, that didn't really work. And a couple of days later, we had a conversation with the agency that wanted to say, okay, what can we do to bring social health insurance? So National Assembly had told them, we said many times, we think you should find options that can be financed through social health insurance. Stop, pushing for other options. This is not what we're interested in. And incidentally, that was something that, social health insurance was the option that we had favored from the very beginning, but I found not a lot of takers up to that point. So we started looking at what were the reasons why social health insurance was such a big no from the beginning for the very agency and program that were supposed to find money for HIV. So they would start telling us all the challenges, and one of them, the main that they thought they were facing, was the fact that the Vietnam Social Security, who handles the fund and directly controlled by the Ministry of Finance, had no idea how much HIV would cost to them, so they would never sign up on something. So it was a problem of evidence in that case, and we were very happy to provide that. In fact, one of the documents that allowed us to have meaningful conversations at a higher level was the study that we did on financial liability for HIV through the social health insurance. And we were able to show that in 2020, if the program would achieve the 1990 targets, the cost to the health insurance fund would be less than 1% of their overall cost. That seemed to struck a chord with the Ministry of Finance and the managers of the fund, which gave their okay. If we could solve, it was like one of those riddles. If we could solve the next four challenges, and then one that I told you about before, people with HIV did not have health insurance for the vast majority. Clinics that were previously funded through PEPFAR were considered preventative type clinics that were not allowed by law to sign contracts with social health insurance. ARV procurement was a big problem. If we had to provide drugs to the health insurance system, the normal legislative way for the SHI program to pay was to reimburse hospitals that would autonomously purchase drugs. So you can imagine a hospital trying to purchase ARVs. They try, price up, 10 times as much as accepted prices. So that was also a big no. And there were some concerns about financial constraints on users, on patients. They would have had to pay about 20%, up to 20% co-payments through social health insurance. So, I can go through all the ways that we try to tackle each of these problems. But one of them, the issue of not having enough people enrolled in health insurance fixed itself as soon as PEPFAR said, you know, beginning from 3 years from now, we'll have health insurance taking care of this issue, so people have to start enrolling. That was enough of an incentive. We worked with individual facilities and the BAC, the Agency for AIDS Control, to integrate facilities into the social health insurance by providing, a step-by-step approach that was going to be standardized and used across the country. And again, working with the political side, working with the decision makers, we have to provide local talent that had knowledge of legislative affairs to help draft a piece of legislation for the government to allow the health insurance fund to start procuring centrally ARVs. And that's something that, we probably are the most proud, because that involved the Prime Minister and having him to sign a decision in 2016 that completely changed the nature of the health insurance fund. Now, I want to point out that the reason finding talent is not the big difficulty. Finding people that can figure out the liability of health insurance is not a big deal. Trying to figure out the cost of ARVs and trying to find, evidence to show that that's affordable is not a big deal. What was difficult was to convince, the top decision makers that it was worth to do what they had done for HIV. Okay? So the most difficult conversation that we had was to try to enact pieces of legislation that were specifically geared at improving the lives of people with HIV. That was not something that we would be able to really bring into meetings. So that's where the UHC discussion came very handy and very useful. Under the umbrella of universal health coverage, if we could show that including key populations were part of that, that was a much more palatable discussion. Having HIV included in social health insurance rather than publicly funded vertically, that was a much easier subject. And telling the Prime Minister and people at the social health insurance level that sooner or later they would have to figure out a centralized procurement system for cancer drugs, for a lot of other drugs that are not easily sourceable locally. That was also a winning argument. So it's not the talent that is needed. I think it's the ability of reading the political situation, the political economy in that point in time. Not all the time. I don't know if 5 years from now, we could use the same argument. In that time, reading the situation, we were able to have those conversations using, small, hiding under larger umbrellas that made a conversation possible. So I think if there is one lesson from Vietnam, is exactly that it's not enough to bring the evidence, it's not enough to bring the capacity to bring the expertise, but to act as a catalyst, you really need to have to find a way to make certain arguments palatable and to find a way to go beyond the specific targets that we are interested in.
Thank you, Naz. I would argue that's a talent. And also, now I realize, I'm reminded that it's two very different approaches to domestic resource mobilization, but one thing you have in common is it was about health. It was about the legislative network for UHC, the social health insurance for health writ large, even though you were accountable for ultimately covering an HIV population. So that's, now we are open up to questions. Oh, wait.
Hi, I'm Christine Ortiz. I used to work for HFG and perhaps Associates, and I work for University Research Co. And thank you for the storytelling approach. It is so refreshing not to have PowerPoints, and it allows me to ask you for a little bit more detail in your stories, because I really do appreciate that while we are all comfortable talking about the dollars and the money and the data, we don't often talk about how important governance is to making sure that that money gets to the most vulnerable. So a question for each of you. One for Elaine. The media, how did you use that to leverage the motivation of the lower level legislators in Nigeria? I think that may have been one of the things that motivated them. If it was something else, please, I'd love to know. And Naz, when I was in Vietnam, one of the barriers that we noticed, legislative barriers, governance barriers that we noticed wasn't just the procurement of drugs, it had to do with the bylaws of the social health insurance and being able to provide care for people who had broken the law, which intravenous drug users are. So I'd be very interested to know how you worked your way around that one.
Just kidding. So use of the media. Well, we actually learned that important lesson by doing the wrong thing. So I'll share that with you all. Doing the wrong thing in partnership with the state. So we had a state, Cross River State, that was trying to pass a bill for state-supported health insurance. This is one of the things that 1% earmarked funding would help support. It was great. The Ministry of Health was on board, the governor was on board, and they had this wonderful signing, and there were lots of pictures, and the media were invited because it was an event. And then the next day, there was stories of governor launches free healthcare program, and we were like, that's not what he did at all. So we realized the hard way that we need to really approach the media in a smarter way than we have done previously. So it was about educating the media, training the media. It was about really engaging them and making them part of the process. So we have these health financing technical working groups in most of the states that we work in, and they're really multi-sectoral. They include the State Ministry of Health, who has constant engagement with the media. They include the media themselves, radio. It also includes the use of social media. Definitely in Nigeria, the legislative network has more thingamajiggies on my WhatsApp. It has more notifications than even my high school group has. Every day there's notifications on my WhatsApp for the legislative network. So also the use of social media. So like I said, we learned the hard way that you need to actually have a strategy for engaging the newspapers, the radios, the talk shows. I've done a lot of talk shows in this area, and I'm still surprised by how many people actually watch them. This is amazing to me when somebody says, I saw you talking about UHC. So it's having an actual strategy, I think, not just, invite them to events. Give them the stuff to say, give them the evidence, give them the numbers from those NHAs and all those other assessments that you're doing. Really give it to them in simple ways that they can't misinterpret. That's the important thing, right? They can't misinterpret them when printing them. So does that answer?
So my very quick answer to your question, Christine, is that, as I said at the beginning, there are certain solutions that are possible in certain point in time. I don't know if what we've done would have been possible just a few years before. Vietnam, at least when I was there, really de-emphasized the criminal part of most of the key populations affected by HIV. They are paying much more attention to human rights for other purposes. They really want to be included in the big economies club. I know now they are cracking down on corruption, things unheard of. People are going to jail. So I don't think the spirit has changed, or the consideration of the stigma is gone. But definitely the understanding that someone is watching and they have to treat HIV as a disease and not as a social evil. Of course, if you're caught doing drugs and if you're caught selling sex, then you're a criminal according to their laws. And there is still some rehabilitation centers, but the 06, 07 they're not as used as they used, to be before. And people do go to jail, but I have to say, by and large, and this is from communicating with people affected by the HIV, things have changed on that respect. So again, things that would not have been possible 3 years ago, 5 years ago, were definitely possible just very recently. That's why I said, the long-term approach, or at least the long-term monitoring, it's something that we need to pay attention to. You might, end up in the wrong time, the wrong place, and think that things are impossible, but just a couple of years later, there will be changes.
Nice to hear about a country moving in the right direction.
Tom Timber, consultant. You'll excuse me because this is going to be relatively specific questions about Nigeria, but this is a subject that I have been following in various ways in Nigeria for a couple of decades. The first question is, the World Bank did a services delivery indicator, which is a key part of its effort to improve the quality of services, both public and private, at the base level. Has that indicator and its limitations or virtues been a factor in the discussion?
You had another one. Do you want to
if you want the other question is, again, highly specific.
Okay.
Sometime in the end of the 2007, 2008, there were a series of seminars which involved the American Actuaries Association and the Nigerian insurance business and most of the multinationals, in which they were interested in creating primarily a health insurance system involving, to some extent, clinics for their employees, but they had discussions with the government about the possibility that the government would buy in for limited income people. Has there been any discussion of the actuarial basis for a national health insurance that would be part of a universal health care initiative? Thank you.
I think I can answer this. On the service delivery indicator, so there have been a lot of, or several of those, several rounds of them. So the service delivery indicator is also the service readiness assessment, availability and readiness assessments as well. I will say this as politely as I can. That information, particularly right now, we've got a set of that that's done by the World Bank that has never been made public, that's never been made accessible to the state government in terms of raw data, the state governments where they were done. And they were finished over a year ago, and we still don't know where that data is. So there's a report that's written, but the numbers aren't there. We've got others, like the SARAs, the Service Availability and Readiness Assessments, where that information is available. And therefore, we've been able to use that. And yes, we have used that actually for DRM. So it's not that those assessments told us stuff we didn't know. We know people aren't trained. We know they don't have the right workers. We know that there are roofs falling in. We know there's no running water. We knew all of that. But we didn't know the extent, the quantity, whether there's differentiation by sort of urban, rural. We didn't know all of that. Now that we know that, we took with the state governments and said, okay, so now what you need is a plan to fill those gaps, a real plan, not we see a gap, but we have a plan that says you need to train X many people, you need to fix X many roofs, and this is how much it's going to cost. And so working with the state governments, both the Ministries of Health and the Ministries of Works, incidentally, in the budget, Ministries of Works and Housing, by far the largest section of the budget. So clearly we need to be working with them because they've got about 6 times more money than the Ministry of Health has. Come up with clear budgets and implementation plans for what you're going to do to invest this money. That's what the 1% CRF is supposed to be doing. One of the arguments we've had from the executive, specifically the Vice President's office, is that we're not putting that money aside because it's not clear what you're going to do with it. We've got roads to build, airports to fix, et cetera, Why should we give you the money when you're not clear on what? And that's really a very valid argument. And I think we don't always take those arguments to heart on health. We just say, he doesn't get it. He does. But we don't give him the right information. So yes, they are useful when they're released, but when there's somebody sitting on them, not so much. So that's one thing. The second thing was around national health insurance. One of the things that is a priority actually of the legislative network is a current revision of the National Health Insurance Bill. The first version of the bill that was implemented over 10 years ago, as I think most people know, national health insurance covers about 1% or less of the Nigerian population. It has not worked well. That being said, if you look at some of the reasons for that, there was no engagement with the states. It was very much a federal level thing and the states weren't engaged. One of the things that the Legislative Network for UHC is very much focused on is making the state and the federal governments really work together effectively. So that bill is being rewritten or modified now. I don't know when it will go back to the House, but it's being done in a much more open and transparent manner. The Ministry of Health is involved, the National Health Insurance Scheme is involved, state legislators are being involved. We'll try to make sure that the governors are involved as well when the governors' forum meets, so that it's a much broader collaboration this time than it was last time. It's not going to be easy getting the private sector, because this will impact the private sector. 3/4 of all health expenditures in Nigeria are expended in the private sector. So creating any bill that doesn't really talk to the private sector is a bit of a waste of time. And this is another thing I've learned from the Senate President. This is a way to turn that on its head. Having this money here provides money for people to pay for services that would otherwise not have been able to pay. That creates a market for private providers. Why don't you sell this message so that it looks that way to private providers? Because it's real. But nobody has done that. The Ministry of Health has always had a focus on service through public providers, and the private providers are sort of a necessary evil over there. And that needs to change. They need to be courted. They need to, their opinion needs to be incorporated, and their views, so that they, really are there to provide the quality services, at least until the government has built up that capacity to really oversee them. We're going to have to use incentives on how we buy services to make them deliver quality services. We don't have the capacity to oversight yet.
Next question.
Thank you for the presentation. I'm Karen Kwok. I'm a family nurse practitioner, public health consultant. So I'm specifically interested in the health workforce reinvestment as a domestic resource, and in that mobilization, maintaining the workers once they're trained rather than brain drain in skill remittances, or in the utilization of community health workers that are being paid, not being considered as in-kind contributions. So I'm wondering, what are the multi-sectorial strategies that have been successful utilizing the Ministry of Health and Education and Labor as to the DRM success in achieving UHC? Thank you.
The short answer to that, at least for Nigeria, is that I can't think of a single collaboration that does what you just said, which is really unfortunate, because what you said makes so much sense, right? Community health extension workers, though, are a really important topic. And there's been a lot of argument over where they belong. They are typically paid by that lowest level of government, the one that I said the money has difficulty reaching. So there's so many problems with that. So one of the things that has happened over the last couple of years is that they've tried to sort of undo, they call it public health under one roof. They're trying to sort of undo some of that decentralization and go from the local government up to the state. So putting all the primary health care under one institution. So the salaries, the training responsibilities, the commodities, the infrastructure, all under one institution, as opposed to having it split up between different levels of government. And that was interesting because in terms of legislation and policy making, it's a great idea. It was a really badly designed policy because it ignored all the other policies. So there's a policy somewhere else that says community health extension workers can't do X, Y, Z. There's a policy over there that says they have to belong to this level of government. There's a policy, there's a policy over there that says money can't flow from the local government up. You can only earmark it, you can only sort of withhold it at the state. So there's all these other policies that contribute to making that one policy a really bad policy. And that's one of the things that, we're trying in the legislation network to fix. That when you have a new policy, it needs to really be reviewed by everybody else so that you make changes to all the other policies that could prevent this one from actually being meaningful. But I'm going to note down what you said because that would be something that should be done. I think we're still in the kind of like in the early stages. There's definitely lots of additional things that need to be considered. And I think the health workforce is one of them, at least via the Ministry of Health, that we haven't given enough consideration to. So thank you for raising that.
Thank you. Could you each say just like a 30-second in terms of the role of the USAID mission as you were pursuing these things?
Yes, and thank you for reminding us of that. I think especially my experience in Vietnam, we would really not have been able to do what we have done without a very strong partnership. I know this sounds trite, of course I have to say that, but it's not a given that technically and also in terms of goals, there is such a great partnership. I think when we started working in Vietnam, neither us nor the mission had a clear idea of what direction we should take. And I told you there were two options. We all knew that we needed to figure out sustainability for HIV in Vietnam. I think we kind of grew together with the mission, especially with the Vietnamese counterparts that had really very strong interest in this topic, and they also had the ability to open us, a few doors, especially at the very beginning, and been involved ever since, And when I say involved, I mean calling me 10 p.m., on a Saturday to arrange that level of involvement. So it was very, 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 very strict collaboration. I think, I can't really overstate that. And I know that you asked that question because I thought we shared, I shared with you this type of role and relationship with them, and it doesn't always happen. So I think that was our key.
So when we started this work, at least under HFG, when we started this work, 2.5 years ago, it was DRM for HIV. And within a few months, it was quite clear we're never going to get anywhere in the states we're working if we pursue this line of attack. So can we start thinking about DRM for health? And the clients, our mission clients, were fully on board with that. They were like, okay. And so they did us quite a big favor. They allowed us to do a few things that we had not been doing before. They reduced the number of states so that we could really build relationships with the states that we were working in. So we went from 18 to 2. So we were able to really build relationships. We were able to really understand what was going on in the context. And it turned out that launching state-supported health insurance schemes were those priorities. So it was, okay, how do we make that work for DRM for HIV? We were able to try some things in those 2 states that led us to understanding the role of the legislature, the role of the Ministry of Information, the role of the media. And we learned those lessons and took them to more states. And USAID gave us the opportunity to expand to more states, which is why we're now in like 18. So those lessons that we learned in states and a couple of different states, we were able to take those to more states and we learned more lessons. And then we really ramped up our engagement at the federal level because USAID had said, no, we've burnt too much money at the federal level and it's just a bunch of meetings, we don't get anything done. But because we'd had some success, we were able to persuade USAID that, look, if we can do it here, let's try. And I remember the first time we submitted a budget for the legislative network, the client who I love dearly, she said, that's ridiculous. You can't spend that much money. And then the next year, when we had room in our ceiling, and we said, can we have X amount of money to do this? She was like, yeah. She saw the value of it because you can see it in terms of there's more media coverage. There's more people talking about this 1%. And so because she was able to see that and she gave us the chance, she could have said, strike through that activity altogether, but she didn't. She said, okay, try it and let's see. So I think them being willing to be flexible and allowing us to really focus on a few and then get larger and build that relationship. They really understood that we need to build a relationship. HIV has been this vertical program. If you want government to really engage, we've got to do more than just say, put money in the budget for this program. It's got to be more than that. And they allowed us to do that. And that's what grew into this.
Okay, thank you very much. Thank you, Chloe. So thank you all for staying for the full session. And just a reminder that this is the first in a series. We have one each month up until May, where we have our end of project conference on May 10th. And Jen says, it's wrote me notes about social media that I don't understand.
I'm old. Just wanted to share, we're launching a podcast, and our first episode is on DRM, so be sure to check us out on iTunes and Stitcher, and we're on SoundCloud as well. And we'll be having subsequent podcasts on health, finance, and governance topics over the winter and spring. Thanks so much.
What would we put into iTunes for this?
Yeah, so it should be Advances in Health Systems. I think that we've named the podcast, and then you can just follow us, and you'll get prompts for any new episodes.